So let's discuss some of the medicine here. The risk stratification you go through and the patient selection for outpatient antibiotic therapy, which is what we've been discussing now. We've sort of morphed from oral, inpatient IV. Now maybe we can do this periodically if we have the right drugs and the right clinical setting. So what are the factors that go into that decision to use an outpatient parenteral antibiotic as empiric therapy, starting perhaps in the ED? In other words, you bring them into the ED and start this right away.
So, well, but just to summarize the opportunities. So one opportunity is in the ED where the setting is avoid an admission by infusing the antibiotics in the ED. There are two additional settings. One is before the ED. You know, we have all those urgent care centers whose mission is actually to avoid unnecessary admissions and unnecessary ED visits, and you can actually start that before the ED. Those patients don't have to appear in the ED. It will be actually less costly to care for them at an infusion, at a wound center, at an urgent care center, than to send them to the ED.
So if I understand what you're telling me, someone goes to an urgent care center, colloquially known as a doc in the box. I hope I'm not offensive, but that you know what I'm talking about. It's that center. They start them, and then where do they send them?
Well, they can. Well,
or do they continue it there?
Oh yeah. They can. So they can continue to follow. So where the follow-up is going to be. So they can follow up the patients. They can send the patient to his primary care physician for follow-up. It depends on the setting, but it's a setting where many of those urgent care centers do have infusion capabilities, and so that's one setting before the ED. Then you have the ED, and then the third one is actually an inpatient, because you can sometimes prevent longer admissions by using longer acting antibiotics that we can discuss later. But talking about the ED, if you want.
I think if you're looking at a patient, severity of infection is the first thing we look at. So, you know, do they present with a septic type of picture? Are they hypotensive? You know, are they tachycardic? Things like that. You know, do they have high risk involvement area? Do they, you know, have a picture of necrotizing fasciitis? Anything like that, probably not appropriate up front for being able to send straight to an OPAT strategy. So, but I still think it's two sides. Even if the ones who are admitted still could be candidates later on to be able to try and get out early and do that.
So, I mean, no one is going to send home somebody in gram-negative septic shock.
Right.
One would hope.
Right.
And necrotizing fasciitis is really scary. So how do you clinically differentiate these patients? I mean, let's take these real sickies. Someone comes in with a blood pressure of 80, a temperature of 104. He's going to the hospital.
Yeah.
But there's a middle ground. What's the clinical judgment
Well,
here?
so many of those patients don't appear very sick. I mean, as we started earlier, most of the patients with skin infections have a localized infection with some systemic manifestations. Sometimes they don't even have systemic manifestations, and the most common one would be a fever. So in our emergency department, we kind of educate our ED doctors to ask 4 questions. One is the patient has any severe deep soft tissue infection like necrotizing fasciitis and so forth. And for most patients, there's no suspicion. Every once in a while, there's unproportional pain. The patient is very septic when the infection doesn't appear to be that impressive, but in most patients, there's no sign of that. Then we train them to ask, is the patient comorbidities are out of control and exacerbated? And as you heard, I mean, many of the patients actually don't have comorbidities, and most of them, the comorbidities are fine. Then we train them to ask whether the patient is septic or shows any early signs of sepsis. And again, most skin infection patients do not. And then the last question, if you want to qualify them for going home rather than being admitted, is anyone at home who can assist them? You know, they're going to be sick for a day or two. Someone needs to give them some water and prepare some food for them, and you don't really want to send them home. And most patients, as you know, do have support, but some patients do not. But if the answer is no, 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 and no, those surveys that were published recently show that in most of the patients who actually get admitted, the answer for those 4 questions is a no, and yet they still get admitted.
So is it that they're getting admitted because people haven't learned not to? Or is it they're getting admitted because there's no infrastructure to support them as outpatients and get this going?
I think it's a big side of it. I think if you look at these patients, you know, many of them have failed orals, or, you know, whether they have, it's a social support issue at home, it's a comfort of being admitted, being able to control. And then I think monitoring is a big side of it. So, you know, do they have proper follow-up if they are sent straight out from the emergency department to where they don't come right back?
So can any hospital right now, without thinking about this in a more systematic way, say, okay, from now on, we're going to take all of our really severe, or not even severe, but SC, what is that? SSSI, gosh, that's a lot of I's, and S's. Can they just say right now we're going to start and do it? Or do they need to think more about it first?
Well, I think that if you want to put together a program and you want it to be successful and you want it to be used as a measure of success, the first measure of success, you have to make it feasible. And so, for example, I can give you an example from our emergency department. So patients come to our emergency department, and as you know, the decision that the patient would benefit from IV antibiotics, I don't think is going to change anytime soon. So I think that the same proportion of patients with skin infections are going to be labeled as will benefit from IV antibiotics. But the question is going to be whether those IV antibiotics have to be given in an admission or could they be given in an emergency department or infusion center or wound center. That's going to be the main decision, I think, from now on in the emergency department.
Right. I guess where I'm coming from is, all right, everybody watching this broadcast says, what a great idea. I've got ABSSSI patients. I want to treat them as outpatients with IV therapy. And starting today, my ED is going to give them a first dose and say, please come back.
Right.
Good luck with that.
Well, so we told our ED, so what we have done, we have a wound center. Someone else has an urgent care center next to their institution or have a walk-in medicine clinic. And we leave a few appointments in our wound center open for ED calls for patients who are seen in the ED and need to be followed. And so when the ED doctor wants to discharge them, he knows that they can come to the wound center and he won't have to fight for an appointment in 3 weeks. And so if you do that, you make the program feasible. So that's one example.
Yeah, I think you got to look at what kind of infrastructure you have too. You know, what does your emergency department look like? Do you have ED physicians, ED pharmacists? You know, how's your case manager structure? Do you have an infusion center as a part of your hospital? Who is in charge of setting up follow-up visits? So I think you got to look at infrastructure and what is feasible from your particular environment.
Nobody, from a patient's perspective, wants to walk into a combat zone 3 days a week where there's gunshot wounds and MIs and everything else floating around. You want to go in and get a pleasant experience and have your antibiotics.
So we already do that. You know, people come with pneumonia.
Yeah.
Well, but people come with pneumonia. You know, for a very long period of time, people come with pneumonia. They don't seem to be terribly sick, but they have a fever, they're coughing, they have a patch on their x-ray, you know, they may not be 80, but they may be 50 or 60, and they'll get an infusion of ceftriaxone that can be infused relatively quickly in the emergency department and then pills. Who's doing the follow-up? You know, a lot of patients who come to the emergency, you come with chest pain. They do an EKG, maybe you have stable angina. I don't know. Who's going to do the follow-up? And so I don't think that we have to recreate a system. We just have to channel those skin patients. Until now, there was no other way. You had to admit them, and therefore we didn't have a system an alternative system. But now we understand that there are other ways because we have infusion capabilities out of the hospital, and now we have several antibiotics that we can give as one infusion.
We're going to get to that too.
And so now we are creating the support for outpatients.